In our final lecture here on distributive ethics, I want to look at the section on microallocation. Microallocation is just the reality in which um, healthcare, the healthcare system really is unable to provide for all of the possible needs and desires of patients. So there is a consistent need to distribute healthcare in a limited way, in a micro allocation way. Your authors note that this is done both by individuals and institutions on a daily level, such as in nursing homes and in hospitals. But we're also going to look at some kind of larger macro economic and other ways in which we have to make decisions about who to treat and when to treat. And just in terms of an ethical principle, and we'll come back to this at the last slide, but your author notes that society must assess its own needs and the limits of its obligations, but we have to make sure that we're not overlooking the dignity of the person. That's kind of the ethical standard that we're hoping to achieve, even when, and especially when, resources are scarce. So we first note that the idea of making decisions about who to treat has a pretty long historic basis. And we found it very early on, particularly in the military, but this functions in emergency rooms today as well. So one of the historic criteria for who to treat injured in the battlefield is to first address those who are slightly injured so that they can be treated and returned to battle. The second would be those seriously injured that require immediate medical attention. And the last to be treated would be the hopelessly wounded. Um, in the emergency rooms, even today, the first criteria is to provide treatment for those who need it in order to survive. So this is going to be those who are having difficulty breathing or some sort of immediate concern that needs to be addressed. The second will be those who will survive without the treatment. And the last, similar to, I think, the military category is here as well, who will not survive even with treatment. So again, this just has to do with emergency situations, but trying to make quick decisions about who to treat. We're going to turn to some of the economic dimensions here as well, and this has more to do not with those immediate emergency decisions, but more how do we allocate costs and resources when we don't have enough. So on the institutional level, there was mentioned a couple times in the chapter about HMOs. And so I just wanted to kind of lay out the positive and negative side of HMOs. The positive side is the attempt to focus resources on preventative medicine. So putting the primary physician as the central decider that will allow referrals out to specialists only after consultation with the patient. So you can see where instead of allowing the patient to kind of go and get whatever diagnosis and treatments they think they might need, going to see your primary doctor who's going to really get a global look at the condition as a way to kind of control those costs. But again, on the positive side is really try to emphasize health and well-being for that patient overall. The negative side that your book mentions, and we have a short video clip in this unit as well that deals with this, is the idea of the case manager or the care manager. I think your book calls it the gatekeeper, who is employed by the HMO, oftentimes with medical degrees, but they will receive financial gain for denying treatments as a way of controlling costs overall. Ideally, if they are entitled to it, they should receive it, but there's a conflict of interest in the sense that part of your financial reward is tied to how you can keep costs down. So the Michael Moore film called Sicko, I know Michael Moore is a bit controversial and he purposely edits and adds music, but I would just suggest that you take a look at this congressional hearing of an HMO case manager where she kind of comes to realization of what she was doing in denying care, because I think that really tries to underline the ethical arguments against HMOs. I also wanted to mention in terms of the economic feature that Medicare and Medicaid are two government-run programs signed into law under Lyndon Johnson, really at a time in America where a lot of civil rights legislation was happening. And this is government-funded health care for particular populations that oftentimes economically are in need of care. So we often think about Medicare as those for 65 and older, but they can also include people who are on disability. You can see that there's a particular attention to kidney failure. This was prior to dialysis. This was a particular area of constant health concern. Medicaid is largely identified for low-income families, but can also include children, people who have ongoing disabilities, pregnant women, things like that. So we have neighbors who, one, the husband practices law, the woman is a teacher, but their daughter has a hearing loss and is able to receive some Medicaid treatment as part of her ongoing medical needs. And as the Venn diagram shows, there's also dual eligibility as well. So sometimes people will, when we talk about healthcare, talk about the dangers of socialized medicine, but really Medicare and Medicaid are examples of government-funded socialized medicine that we have in place now. Other economic dimensions also include sources of funding. So your book broke down kind of two main categories with further subcategories under nonprofits. But for-profit hospitals are really market-based, and for-profit healthcare is being able to provide services for those who have the insurance or have the means to pay for it, plain and simple. Nonprofits can include a variety of categories. One is kind of government subsidized and really owned examples of Veterans Affairs or other types of specialized hospitals for care of vets. Private voluntary, this is often community-based or religiously affiliated. I think we could mention particularly Catholic health services that have a long tradition both here in Philadelphia and beyond. So they might receive some public funds, but it's largely privately funded, and they're going to be able to try to treat a variety of people, not always based just on income. And there's also special voluntary cases where allocation for treatment is based on the potential contribution of treating that patient and gaining greater knowledge for health practitioners. So it's not based on patient need alone, but if the patient is presenting something particularly engaging or interesting, then they can be taken for treatment as a kind of a research and teaching tool as well. So microallocation, as we've noted, exists on individual and institutional rationing of care. And so we have to keep looking at this idea of managed care and the common good. And this is obviously part of our political debate as well. And I just think your book did a good job of sort of noting that while conservatives tend to lean towards the market as a means of allocation, that this approach can often neglect the poor and disadvantaged, and liberals tend to lean more on government as the organizer, and this can really neglect the reality of the scarcity of resources and the necessity of rationing. In the end, your book notes that it's up to patients themselves and families to make decisions given their resources. So the last line of the chapter The uncertainties and trade-offs in this decision are so intractable that there appear to be no clear ethical guidelines for the individual, except that all relevant factors must be considered within the context of society's macroallocation of resources. So, I think again, this ethical ideal of dignity for the patient is what we're aiming towards. But I think this chapter in particular has really kind of struggled with how to do that in a case where we will always have consistent limited resources. Okay, well, thanks for your listening, and we're going to be moving into our Unit 5.